I would like now to introduce Associate Professor Sharon Andrews, who will be delivering the implementation science session today. So Sharon has an extensive background in implementation science. Her research has been focused on aged care and dementia, and really looking at how you can implement best evidence at better patient residents outcomes in that area. And previously, Sharon was also our associate head of research within the School of Nursing. So welcome, Sharon, and thank you for presenting today.
So welcome everyone, and thank you so much for joining online today, particularly at the end of the day. So my name, as Peter said, is Sharon Andrews, and I have the Sydney Harbour Bridge behind me because I'm also located in Sydney, just in case anyone has any confusion. We also have a Rozelle campus in Sydney. And today what I'm going to talk to you about is bringing research into everyday practice and looking at how implementation science care professionals. And really, this is just a bit of a primer to some of the work that we do within our masterclass, which is a day-long masterclass around implementation science. So I just want to talk briefly about really what are the challenges of shifting evidence into practice, some key concepts, a little bit about some of these key concepts in implementation science, what I refer to and others, the how much and the how well, and also some common implementation theories and frameworks that can help you, particularly when you're trying to understand the context within which you're working, when you're trying to shift evidence into practice within contexts that have quite specific needs and a lot of competing factors as well. So shifting evidence into practice is referred to as a wicked problem. And so this sort of problem is one where there might not be a clear definition, there might not be a single solution, and there could be many interconnected factors. We know what the definition is, but what I think makes it a wicked problem is that there are lots of interrelated factors when we're trying to shift research into practice. There's also a lot of work that needs to be done with stakeholders, which at times can be challenging. Solution. I wish I had one for you, but I don't. But what I can tell you is we have a range of tools that can actually help us on our journey. So I think it's important to talk initially about the fact that we have this traditional evidence pipeline. And I'm not going to talk too much here as just a researcher, but to say that there's always a time lag, and sometimes it's quite a significant time lag between the development or new knowledge and then the routine uptake of this into clinical practice to see actually improvements in clinical outcomes. So we always have a time lag. But then once we've actually developed evidence and we've moved through some efficacy trials into effectiveness trials where we know that the actual intervention or where the evidence-based practice actually works, I think it should, and we hope it should, then we get into this space of implementation. And this is where we start to see other problems emerge. And this is when we see this collision, in a sense, of controlled conditions and real world applications. And so what we know is that an intervention, and I'm going to use that term interchangeably with evidence-based practice or an evidence-based innovation, they can in initial trials where a whole heap of conditions are controlled for, and you can think of that as like an ideal type condition. But when we then move into the real world where things are messy and there's lots of competing interests and stakeholders, this is where we can see even very effective interventions under controlled conditions can fail to have the types of positive impacts that are anticipated. Is where we often see an evidence practice gap. Sometimes the evidence isn't translated at all, but sometimes we attempt to translate it into practice, but we also don't actually see the positive outcomes that we hope for. So I wanted to find a diagram, and I had a very long argument with ChatGPT about the diagram that I wanted. This is not quite the diagram close enough to it, to try and show the evidence practice gap. And I know there's other ones around, but I thought I'd try and be creative with some Gen AI. It took a lot longer than what I'd anticipated. But what we know is just because we have evidence-based innovations or even evidence-based guidelines, where we have guidelines that are based on the best available evidence in particular areas of practice, that actually doesn't guarantee healthcare provider adoption. It doesn't mean that healthcare providers are going to adopt the evidence or practice in the way that a particular evidence-based guideline suggests. And it also doesn't mean that there'll be adherence in practice to that evidence or guideline either. And we know that many evidence-based interventions never actually reach real-world application, which is a real shame. We know that on average, 17 years for new healthcare research to be fully integrated into clinical practice, which is a long time. And for some of us, we will be retired by the time some of the interventions or innovations actually come into practice, which have only recently been developed. And we also know that in countries such as US and Australia, the estimated adherence to clinical practice guidelines, where we know that those guidelines are based on the best available evidence to direct practice, sits between 55 to 57% respectively. So really adherence is at best just over half or just under, 2/3 most of the time. And what is perhaps more surprising is that almost 4 out of every 10 people do not get evidence-based care, or they get care that is known to be ineffective or. And so I suppose this is really around developing an argument for why we need to be better at shifting evidence into practice, and what we can do to try and negotiate some of the challenges that we face. So when evidence meets the real world, in a sense, we have this real challenge in implementation. So we're not only in pursuit of the best practice, but we really now, particularly when we work within much more complex systems, need to not only understand what best practice is, but also at times why practice is not consistent with the evidence or why best practice is not actually being undertaken. And one way that I've thought about this more and more over the past sort of years is that you can think about the lack of evidence-based practice, if you like, or the evidence practice gap in a couple of ways. And one of the ways I like to talk about is to think about, well, is there a failure in the intervention? Is the intervention or the thing that I'm trying to implement, is it just not effective? So that's one way. So is this innovation actually not effective in my? Or is the failure because of how the intervention was introduced or deployed, which is really an implementation failure? And so understanding whether there's a problem with the intervention and or a problem with the implementation is really important. And it looks easy because I've just done 2 dot points on the slide there, but that's actually really quite complex to do that. And sometimes you do need particular types of disentangle is this an intervention failure or an implementation failure. But from the perspective of being a clinician, I think it's really helpful to know, well, if you've chosen a particular intervention or evidence-based practice or a piece of research that shows good effectiveness, and there's reason to think that it should be effective in your setting, is the issue more to do with implementation? And the reason, because we know that around 30 to 45% of patients don't actually receive evidence-based care due to implementation barriers as well. So we know that implementation is certainly an issue, and that's really what I want to talk a little bit more about today and how we might be able to manage this. So there is many barriers to implementation of evidence into practice. Those of us who work in this space sometimes wonder why we do, because every time we think we may have found an answer, something else comes up and, there's a whole new challenge to deal with. So we know, though, that there's a range of factors, like organisational factors, like I've mentioned on this slide here, which can be around the readiness of an organisation to change, existing cultural, social norms, what type of leadership there is in the organisation, and obviously resourcing as well. There's also practitioner factors, which comes down to, for example, knowledge and attitudes of practitioners themselves around a particular type of innovation or evidence-based practice. And then there's also evidence-related factors, particularly if the evidence is complex. We know that if there is something quite complex to be implemented, then it's a lot more tricky practice, because we're asking busy clinicians to think about some type of new evidence-based practice, which actually requires them to probably work through a whole heap of complexity to even just understand what it is they need to do. And there's also a range of other external factors. And I've said things like regulation and legislation there can impact how evidence is implemented, and it can impact also as well. And we see this often within the aged care environment, and I'm sure within other healthcare environments, where the impact of the legislation and regulation changes can actually in turn impact other organisational factors, which then also affects how people can manage to shift evidence into practice, or indeed if they have that capacity to do that amongst all of the competing. So to improve evidence-based care, we really, and to look at evidence uptake or guideline uptake in particular, there needs to be close attention paid to the implementation space, which is really what's shown in this diagram here. We have on one side of that on one side of that space, we know that there's something that's effective in terms of an innovation or practice in control, a randomized controlled trial, for example. But then actually putting that into practice and getting clinicians to routinely uptake whatever the intervention is in a sense a whole different ballgame. And that's where we have to learn how to bridge this implementation space. What I wanted to do is just provide you with some key concepts now, because I think that this makes implementation science and shifting evidence into practice much more, if you like. And there's a lot of theories and frameworks that are around, but I like this way of thinking about, what we do, how we do it, how well we do, and how much we do, as a way of thinking about, shifting evidence into practice. So the what is the innovation or the intervention. And as I've said, it may be an evidence-based practice. It may be an evidence-based policy or protocol, organizational change. It may be the implementation of a new treatment. The what is actually what we want to actually shift into practice. The how are what we would refer to as implementation strategies, and they're really the deliberate and purposeful actions or strategies that implement evidence-based interventions or the innovation. So the how is the way that we get the what into practice. And then at, well, how successful were we in terms of moving the what into practice? And that's when we look at how well and how much. So how successful are the strategies that we used, or the how, to actually then make changes in practice, where we look at things like adoption, was the actual evidence-based practice protocol actually adopted into to it? Was it a feasible intervention to put into practice? So there's ways that we can measure implementation outcomes as well. And what I thought I'd do as we move through this presentation is just give you some examples to try and help those things come to life, because it may be helpful for you if you're in practice and there's some type of change that you need to drive or deliver. So I use my Gen AI picture again because I spent just going to use it once. But here I thought I'd look at an example of a pain management protocol. This is from a piece of work that I did a number of years ago. And if we think about, well, what's the intervention or the what, which is what I've just talked about, this is the evidence-based practice or the protocol. So we had a pain management protocol that included systematic assessment, pharmacological interventions, and structured ways of follow-up, and actually quite structured ways of communication between members of an aged care team. So that was the what, the pain management protocol. And we really wanted to get staff to take this protocol and to actually use it in practice. And so the how is those methods and processes that we used. And so some of the methods and processes, training and coaching, so some formal training around the use of the pain management protocol, and then some coaching with clinicians one-to-one. We looked at integrating the pain management tool into electronic health records, and with the use of automatic clinical reminders, and providing an ongoing support and facilitation for clinicians who are using it. So these is the training, the coaching, the automatic, the clinician reminders. These are some of the strategies that we used to actually shift this protocol into practice. And as the little diagram shows there, the how is actually a way that you bridge between this gap and really start to try to look at the ways that you can actually support, whether it's managers or leaders, to actually use whatever that intervention is. It sounds quite simple. It's really, really not. There's many factors that are involved, and I'll talk a little bit more about them soon. But just to start thinking about what is the thing that I want to implement into practice and how can I do it? And there's ways that you can map this and actually develop these, particularly the how strategies as well. So I talked a little bit about the how, and this is really important because sometimes people get confused between intervention and implementation. So as I said, the intervention is the what, the actual implementation strategies are the how. And so as it says on the slide, they're the methods or techniques used to enhance adoption, implementation, and the sustainability of an innovation or an intervention in practice. The work that's been done around implementation strategies shows that there's common strategies with consistent small to moderate effects. There's no one strategy can be found that's effective across all settings. I'd love to be able to say to you, everyone needs to do a process of audit and feedback to their staff, because that's going to help them implement any innovation or evidence-based practice that you've got. That would be lovely, but that's unfortunately just not the case. What has been found is that it takes multiple strategies that are mapped to barriers within the particular practice setting that are then the most successful at actually promoting the uptake of whatever the innovation is in practice. So I've given you some examples just adapted from a table that really just shows what are some of the ways that we actually can implement innovations. So there's audit and feedback, and this is effectively over a period of time providing feedback more than once to clinicians or to supervisors against whatever the specific target is that you're trying to actually implement in practice and then monitor and evaluate. Audit and feedback clinicians with a way to see how they're progressing, and in some sense to provide an incentivization to try and do better. So that's a common one that you'll see within implementation science and within practice change articles as well. Clinical reminders, these are systems that are designed to basically help clinicians recall information and prompt them to use an innovation. We see this a lot. They might be automated on-screen reminders. Again, this is not a panacea, but we know that these sorts of things can be quite helpful when you're wanting people to change their behaviour and their practice in the midst of a busy day. So clinical reminders are one of the strategies that has shown moderate effects. And then there's other strategies such as educational outreach visits, which are done into the setting to provide face-to-face information on performance and how that can be maintained in relation to the uptake of an evidence-based practice. Not surprisingly, local opinion leaders are very important, and there's also educational meetings as well. So this is just some, and there is papers that actually look at a range of these implementation strategies. Gives you a bit of a summary. The main thing is for you to think about that there is a range of strategies that are the how-to strategies. How do I shift this into practice? And they're useful in terms of understanding what you might need to do in terms of to address some of the barriers that you might face in practice. There is also a range of implementation outcomes, and how much and how well. So this is really something that we look at as implementation outcomes once we've put an intervention or an innovation into practice, and then we look at how successful we've been. What I haven't gone into too much, but we will go into this a lot more in the masterclass, is that in order to actually develop these implementation strategies, we need what may be the barriers to shifting evidence into practice. So back here, when I talked about the range of barriers, organisational, practitioner focused, then if, for example, there was organisational barriers where there was very heavy workloads, where staff, where you had good evidence to suggest that staff had particular aspect of a protocol, that's where, for example, like a reminder might be helpful. So the mapping of these sorts of techniques, the implementation strategies, isn't really, it's not our best guess. It actually follows a very systematic way of looking at what are the practice barriers, what are the barriers that are going to potentially evidence is accepted, taken up and adopted in practice, and then how can we deal with them. So I'll just come a little bit more to that, but I didn't go too much into the barriers analysis, but that is something that is absolutely crucial when we're doing implementation science, because we know that these are things that impact massively on how evidence is taken up. So I have a range of implementation outcomes, and so this is really about saying, when we've used the range of implementation strategies, it may be audit and feedback, it could be clinical reminders, and it may be education and coaching for staff. Then it's like, well, we need to actually understand whether it was successful or not. Did our implementation strategies work? And there's a range of different outcomes that I've provided on this slide. To be honest, not all research or all quality improvement projects actually report on all of these outcomes, and there's a variety of reasons why that might be. But I think it's also important to say that these are specific outcomes that are worth considering, and they're also worth considering early when you're thinking about planning an intervention, planning an implementation for an intervention. Is acceptability. So this is the perception amongst your stakeholders, whether it's staff, if they're the target of the implementation activities, or whether it's managers or whoever. It's the perception among implementation stakeholders that the innovation is agreeable or palatable or satisfactory. And it's usually measured from a stakeholder perspective. And so important, because you can have an intervention that is appropriate for a setting. And you can see at the third row down, we talk about appropriateness. This is the perceived fit or the relevance or the compatibility of the innovation to a setting or a group, or to address a particular problem. So you can have an innovation, for example, that might be acceptable to staff, but it may not be appropriate. And so these are some of the things that you not only consider after when you're doing an evaluation, but also when you're actually planning for implementation as well. And there's some tools that can help you do that. But I want to give you an example. We did a study recently where we looked at the implementation of a yoga and mindfulness some residential aged care facilities. And what we found is that the staff considered the intervention to be highly acceptable. They thought it was great. They thought, yes, it fits the need. This is highly acceptable in our service. We like the idea of this. This is not something. This fits well with our mission. What we found when we did an evaluation is that it wasn't particularly appropriate for the setting. So the setting and if any of you work in residential aged care, you know that there's a massive amount of changes that are happening, and the setting was struggling with staffing their services to meet the new requirements around nursing minutes per resident, for example. And so what we found is that while everyone thought it was highly, wasn't appropriate at this point in time, because people were so torn between short staffing and problematic resourcing. So some of these things you can actually identify pre-implementation. But if you haven't, or you've already got a program where maybe you're implementing something, you can also apply these retrospectively to the implementation and ask stakeholders about these outcomes and get them to reflect on them, particularly those people who've been part of the implementation. So we've got acceptability, adoption, this is the intention or action to try and use the innovation. It's also referred to as uptake. And so often people will measure adoption as one of the key outcomes of implementation. What percentage of our staff is now, using the new pain protocol? What percentage of our staff has changed their practice to reflect whatever the new evidence-based practice was? Appropriateness, I've talked about. Cost is really important also. So in terms of the cost of the implementation, and there's a lot of variabilities in cost, but I think from a perspective of us as researchers, we with research funding to trial an implementation of an intervention in practice. But the cost component is often, well, what happens when the research funding, for example, runs out? Where does that leave the organisation, and and that links into sustainability. How sustainable will this be in the future for the organisation if it costs a lot to continue practice, for example? And cost may also not just be cost of delivery, it may be cost of particular implementation strategies. It also could just be the cost of an intervention if the intervention was very expensive as well. So again, this is not always reported on, but I think these are things that are very helpful to think about either as part of a program evaluation or prior to actually and pre-implementing something. Feasibility, the extent to which the new innovation can be successfully used in a particular setting, and is an intervention actually feasible for the staff to pick up and use? It may be acceptable, it may be appropriate to their setting, but is it actually feasible? Or do staff say, look, I can't see that happening in my practice. I can't see myself being able to change my practice for reasons A, B, and C. Fidelity is the degree to which the innovation is implemented as it's intended. And so again, this is where, I suppose implementation science and people who practice implementation science are often looking at, if something is implemented, if it's a, for example, a hand washing protocol, is the protocol being used as it was developers? And that's really important, because then otherwise you get shift away from the evidence-based practice. And it's not always a bad shift. Sometimes it is, but it's really important to understand those issues around fidelity. And then there's also other considerations which really are not reported on particularly well in the literature around penetration. So the extent to which the innovation is integrated within service settings and its systems, so that greater penetration across the system. Sustainability, at the extent to which it can be maintained and institutionalized. And that's often also related to penetration. What we don't see is as much being written about penetration and sustainability. And that could be because we work in highly complex systems. It could also be to do largely with research funding and funding for innovations, that, being able to get to the point of penetration and time as well. So they're just some considerations. So really the take-home message from this is that there's specific strategies that we use to shift evidence into practice. There's ways that we map those to key barriers within the setting where you might be practicing. And then there is a range of implementation outcomes to see really, well, how successful are we? And what might we need to do differently in the future as well? Because we isn't just a one go, and then we've done it and it's all done and dusted and successful. In fact, in my experience, and I'm sure in Peter's experience as well, implementation often takes many cycles, and it takes a lot of deep diving to understand why things didn't work. You often have to understand why things didn't work to understand, how things will work. And so this really is just an example of a very common, evidence-based practice, hand hygiene. And this is really from an implementation perspective. Perspective is not spelled correctly there, but that word should be perspective. So, we know very good evidence. We know that, implementing hand hygiene with very good evidence to support it. And a protocol might include, for example, the specific techniques for hand washing, the frequency, the consistent use of alcohol, based sanitizers, whatever the protocol might, for example, include. So that's the what. The how is the implementation strategies, and educational meetings and educational outreach have been found to be. What's really interesting with hand hygiene is that something that really changed the state of play with hand hygiene was the installation of hand sanitizer dispensers, and in places such as at the ends of beds, because it basically functioned as a reminder for staff. And so really understanding the reasons why staff, not because they didn't want, I didn't think it was an acceptable or an appropriate innovation or intervention. What some really good analyses showed of one of the key barriers was that actually walking to, for example, the hand basin each time after each making contact with each patient actually took a lot of time and resources, and sometimes people also forgot. Just providing a reminder was quite a big game changer for this type of intervention. And there was also regular audit and feedback as well. And there's a number of articles that have been written around how hand hygiene has, the protocols and the processes that have been used to improve hand hygiene. And then we'd be looking at, if we were implementing this, the how well and how effectively and to what extent was the protocol adopted. And so we might be looking at things like monitoring hand hygiene compliance rates. I was just speaking to someone in our postgraduate gerontological unit today who talked about that she was actually an auditor for hand hygiene at her service. So, monitoring hand hygiene, looking at the adoption rates, how often are they using the products, conducting surveys, or you might look at, willingness for people to use. You might be looking at surveys about the appropriateness of the hand hygiene protocol, and also getting feedback on how the protocol aligns with workflows. So these are all things that, as you can see, if we have a really good understanding of what the intervention is, what the barriers are, we can map some of these strategies to look at how to really try and bridge that gap between the evidence and practice. And then once we've actually put the intervention into practice, also looking at, well, how successful have we been when we're looking at those implementation outcomes. So there are, as I said earlier, a number of theories and frameworks. I've literally only provided 3 here. There's many more. The most commonly used frameworks that help guide us within this space of implementation science would be the Consolidated Framework for Implementation Research. And it can be used prior to implementation, so pre-implementation, to help with identifying barriers, mapping implementation strategies, but it can also be used for looking at evaluating the success of implementation as well. And there's the website there, but there's a fantastic website about the CFIR tool and the associated tools that you can actually use with the CFIR. So interview guides, for example, there's a whole range of other tools that actually help you use this process to help you pre and post the implementation activity. The RE-AIM framework, this is largely evaluation of implementation efforts, and I've given you the website there. But effectively, this is something that you can use if you have implemented something in practice and you want to know how successful that implementation was. And there's also the promoting action on research implementation in health services. And it can be used pre and post implementation as well. It's a tool or process looking at planning and designing strategies to promote implementation, evaluation, and also a facilitation of change component, which is really important as well. So I don't have time to go into each of these strategies, but I just wanted to show you as an example, and not wanting to scare anyone off, is that the consolidated farm work framework for implementation is really a very comprehensive multiple construct tool which looks at the innovation itself, the inner setting of a location where you might be implementing an innovation, such as, you know, it might be a hospital ward or a residential aged care facility, the outer setting which sits around that, who are involved in the implementation, and the actual implementation process itself. I'm not going to go through all of these domains, except to say that, you know, you can actually interrogate each of these domains with respect to where you would be working, and you can do that pre-implementation, and you can also look at it as a post-implementation framework as well. And there's also other tools on the website around how implementation strategies, and they've recently included a behaviour change framework with this tool as well. I think it's a great tool. It does look very complicated. And so, you know, this is something that takes a while to learn how to use, or, you know, if you have at your disposal, you know, people who actually work within implementation science, I always say, you know, getting some feedback from people who are in the know be helpful, particularly for clinicians who might not have used them before. But the website is great, and you can definitely go and look at the tool there itself. But just to give you an example of how comprehensive some of these theoretical frameworks are as well, and this one in particular has been published quite widely across a whole range of areas, including healthcare, but not just healthcare. So I'm aware of the time, and I wanted to give people enough time to ask any questions if they can. I'm not sure. I think maybe they can. Correct me if I'm wrong, Peter or Michelle. But I suppose what I want to leave you with is some summary of points that shifting evidence into practice is a really complex process. And if it hasn't worked for you, like it hasn't for many of us, that's pretty normal. And it is a process that it takes a lot of effort and a lot of understanding, and good quality evidence does not ensure good quality practice. And so it is about us taking time to really understand the implementation context. What are the barriers? What are the facilitators or the enablers that we can leverage? And how do we map strategies to those barriers and enablers for us to try and, you know, support the implementation of evidence, whether it's at whether it's at an organisational level or even at a policy level. The barriers to implementation occur at all levels, and we need to understand that and look at how we might address some of those, and or indeed the key barriers that particularly your stakeholders tell you exist. And as I just talked about, there are implementation theories and frameworks and models that can assist with understanding of the setting within that implementation mindset. And as I said, mapping strategies and evaluating implementation efforts. It's probably all the time I have to go into that today, but certainly within the masterclass that we do, we have time allocated to work through some of these tools, and we will have worksheets so that people can start to operationalize some of these sort of and really using them into a real world environment, hopefully that you can take back into practice. So I might leave it there. Thanks, Peter.
Thank you very much, Sharon. That's a great presentation. Are there any questions for Sharon? So if you have any questions, could you please put them in the question and answer box?
will the recording be shared?
Yes, it will be shared, and they'll be on our website as well, and on the UTES website. But you will receive an email.
I think maybe everyone's ready to go home.
If there are no further questions, and if you're interested in implementation science and particularly from a more practical point of view, as we both mentioned, we do deliver masterclasses, and so you will receive some more information about the masterclass enroll as well. So thank you very much for attending today, and thank you again, Sharon, for presenting. It's been a wonderful presentation, and have a good night, everyone. Thank you.